I wanted to welcome you to our great webinar today, the National Zero Suicide Initiative, Levers for Maternal Mental Health. So a little bit about who 2020 Mom is. We are a national nonprofit that works to close gaps in maternal mental health care. We provide the tools to convene, and we generally work to close gaps through policies and systems change.
And Cindy, I think you're ready to introduce us, and we just lost your camera. Here we go, right? The technology issues to start. I think Cindy will hopefully be popping back on. Why don't we each take a minute to introduce ourselves, if you don't mind? We're going to do this the way that we need to, and I'll start first. You just met Cindy Lee Herrick, who's on the 2020 Mom team. She's our partnerships and campaign lead. And Cindy has led our suicide awareness campaign for the last several years, and also was the person behind putting this suicide webinar together, featuring the Zero Suicide model. So glad to have Cindy with us. My name is Joy Burkhardt, and I am the founder and executive director of 2020 Mom, who you heard about just a moment ago. I'll be joining us at the end of our session today to moderate the fireside chat. You'll have an opportunity to include your questions in the GoToWebinar control panel. Usually that shows up on the right-hand side of your screen. Feel free to add those questions now. And I'd like to ask our two speakers to go ahead and introduce themselves, and we'll start with you, Dr. Goldstein, if you don't mind introducing yourself.
Yeah, good morning or good afternoon. I'm Julie Goldstein Grummett. I'm a psychologist by training. I'm the director of the Zero Suicide Institute. So we provide consultation and training to healthcare systems looking to adopt zero suicide. And I'm in Maryland, just outside DC. Pleasure to be here. Ed?
Thank you.
Thanks. My name's Ed Boudreau. I'm a clinical psychologist by training. I work at the University of Massachusetts Medical School in Worcester, Massachusetts. My area of specialty is in figuring out how we can modify the systems of care, the way our healthcare systems provide care, so that we're better able to identify individuals who are at risk for suicide and intervene with the right interventions at the right time. Not just relying on clinicians to be able to do a good job and to be trained individually, but also to build an entire system of support to be able to support those clinicians, patients, and their families, so that we can reduce the suicide rate.
Great, thank you. And I don't think we have Cindy back yet, so I'm going to share my screen.
I can give a little bit of background, Joy, if you want.
Yeah, if you don't mind giving a little background while I pull up the presentation, that'd be great. Thank you.
Yep. So as I said, I'm with the Zero Suicide Institute. The Zero Suicide Institute is part of EDC, the Education Development Center. EDC is also home to the Suicide Prevention Resource Center. So we are a part of the federally funded Suicide Prevention Resource Center, which also hosts the National Action Alliance for Suicide Prevention, which is where zero suicide first began to be established. It was really the idea that the first national strategy was launched in 2002, the first national suicide prevention strategy. There was a new national strategy in 2012, and in 2012, as the task forces for the Action Alliance were coming together, they really said that suicide prevention in healthcare needed to be a goal of the national strategy. It was not included in the first national strategy in 2002. And I'll talk about that. I don't know, Joy, if you have our slides, and if not, I'll just keep on going.
Keep going. They're almost up. Thank you.
Okay. So the idea was really that healthcare is an area that obviously people are getting their suicide prevention and care needs met, but the assumption was that healthcare is already suicide for people at risk for suicide. And if any of you work in healthcare or have had to utilize the healthcare system, you know that's probably not true. As a psychologist, I happen to have a lot of interest in suicide prevention, and so I had a lot of training, but for the vast majority of people, it's the kind of thing you really had to seek out. It's not mandatory, it's not part of graduate program for social work, psychology, psychiatry, a little bit for psychiatry, but that's really about it. It's with the exception of a few states, CEUs and suicide prevention are also not mandatory. And so really what we're doing is we do a lot around gatekeeper training. A lot of the national strategy is to identify people at risk, whether it's via church and faith or schools or other types of peers and family, with the idea that if we can just recognize somebody who's at risk for suicide and then get them to a healthcare provider, we can keep them safe. And while people in the healthcare system who work there are doing their best, and they're really working very hard, and there are exceptional clinicians and healthcare professionals, the fact is you don't have training in what evidence-based practices are or suicide-specific care. You can only do so much. And so in 2012, they adopted goals 8 and 9, which really focus on zero suicide as being a goal, that healthcare needs to be ready, that healthcare clinicians are trained and have the competence and the skill to care for people. And so that's really where zero suicide developed from. At the time, we also know that the vast majority of people touch the healthcare system in the year or even the month before. So we're missing opportunities, right? So if people are they're coming into the emergency department with a broken foot, but they're not being asked about their thoughts of suicide, most people aren't going to readily say when they're there for a medical issue, I'm also feeling suicidal. It may feel very overwhelming to them or to their family, and so they're just not well positioned. They've been very traumatized from other times they talked about those experiences. They don't know what's going to happen, or they told somebody and then they didn't really get care that helped them to feel any better. And so if that's the case, why do you keep telling people? So really, zero suicide says the burden needs to be on the healthcare system and healthcare providers, not people at risk. It's really unfair to tell people at risk, you need to disclose your thoughts and then we'll help you. That's unrealistic. And it's our job to really tell people what that care looks like and to do screening and assessment. So we know that people also go to their primary care doctor. They go frequently as they get older, certainly. We want those primary care physicians, and in this case, OBGYN, pediatricians, to ask people about how they're doing. We know that many women in the first year after having a baby is one of the highest times for depression. And so pediatricians have the opportunity to pick up on that and to ask people. It's a simple question, but by putting the burden on the healthcare system to ask, on providers to ask, it opens up conversations. Asking that never puts the idea in somebody's head. In fact, it's often it's much of a relief because people are finally being asked about something that they've been carrying around and didn't know how to tell anybody, or they had sort of told family members who really didn't know what to do. You can go another slide ahead, a couple more slides. Go to the next one. Can you stop there for go back 1 second? Go back to the SPRC slide. I just want to talk for a moment about SPRC. If people aren't familiar, go back one more slide. So I just want to, if people aren't familiar with the Suicide Prevention Resource Center, SPRC.org, the SPRC covers all age groups, all settings, all healthcare settings. It covers community as well as healthcare. There's a lot of training on the website, and there's materials. We have something called the Primary Care Toolkit. We have a lot of resources and programs, online training. We talk a lot about effective prevention. There's a lot of material there for state coalitions and other types of different people who are involved in suicide prevention. And it's just worth your time if you're not familiar with it. It's really the clearinghouse for resources for the country. Next slide. Next slide. One more slide. Great, stop there. So these are the 7 elements of zero suicide. I've talked a little bit about kind of the theory behind why zero suicide was first established, really this idea that healthcare systems can do more. People are touching the healthcare system. We know that, and if we ask, people will tell us. So zero suicide is comprised of 7 elements. These are those elements. I'm going to walk through each of them. It's really a bundle of evidence-based practices that when used consistency, with fidelity, and when all people in the system are trained to use these practices, then healthcare systems that have used this approach have reduced suicide by about 65 to 80%. Next slide. So I mentioned some of the statistics already, that the vast majority of people are already touching the healthcare system. As I said, it's often not mental health. Often when I said people touching the healthcare system, I'm really talking about emergency departments or primary care or other types of specialty care. And so when we talk about zero suicide, we're talking about the entire healthcare system being suicide ready to identify people at risk and to refer people at risk, but also to have pathways established and follow up to ensure that people go to those appointments and understand what their roles are. But not just mental health, because, you know, as many of you may already know, people often don't go to those follow-up appointments. And I think it's our job to really do a better job explaining why. You know, I often use the example, like I have a daughter who's has a congenital heart defect. And if somebody had not said, when I went to go meet with the surgeon for her care, if he had said to me, when I was saying, how do you feel about doing this surgery? If he had said to me, I'm going to do my best. You know, I had a little bit of training. I don't know this particular surgery very well, but I'm really going to try hard, right? I would never let him work on my daughter, my infant. But that's, I think, what we're doing in healthcare, unfortunately, because people aren't trained in suicide prevention and care. And we think that they are, and we can do better. There are evidence-based practices. I'm going to talk a little bit about them. Ed's going to give you some examples as well. And we can do better. And so why do we accept that in medical care, we will get evidence-based practices, and we expect that no matter if we're in, you know, Kentucky, New Jersey, you know, Hawaii, if we walk into an emergency department, we expect that we're going to get evidence-based treatment that focuses specifically on our symptoms, using absolutely the most, you know, cutting-edge resources available. And we deserve that in medical care, and we deserve the same in behavioral health care, but we're really not there yet. Next slide. So much so that the Joint Commission actually also said this is time, right? This was pretty groundbreaking. And for any of you who work in healthcare systems, July 2019, they released new requirements for around the National Patient Safety Goal for risk of suicide. This is really pretty groundbreaking for the Joint Commission to adopt these standards. It really moved it from this idea that if you had the resources to do better suicide care, then do your best. It moved it to being a requirement of doing better screening and better processes for suicide risk assessment and monitoring people from discharge. So a lot of healthcare systems are still kind of coming up to speed on this and still trying to understand what this means. Later this year, Ed and I and a couple of others are actually going to release some other webinars to talk about the Joint Commission standards because they are so new and nuanced. But I think this was really a pivotal moment and really a flag to suggest the time has come that suicide care and behavioral health care is really critical. Next slide. So zero suicide is really meant to be an aspirational goal. It focuses very heavily on error reduction, never events, using continuous quality improvement. It's a series of evidence-based practices, but it is absolutely critical that it focus on filling the gaps that exist in suicide care. The idea of zero suicide and zero, not everybody loves that name, but I think really if you think about it, is there a better number? I know when I led DC's state suicide prevention efforts for many years before my current job, and we'd often talk about reducing suicide by 10% or reducing suicide by 30%, and that's really challenging to do and really hard. But is it sufficient? Right? I think when you apply all of the different kind of thought processes and dedication, when you're aiming for zero, you work very differently than if you're aiming for 10 or 20%. And so it's an aspirational goal, but the idea is that the culture surrounding that is very thoughtful and a just culture that's constantly learning and improving. Next slide. So some of you might be familiar with this. This is James Reason's Swiss cheese framework of accidents. It really also helps to picture what happens in suicide care. If the holes line up, then people often are faced with serious injury or death. And this is kind of what healthcare looks like right now for people at risk. Next slide. So I mentioned that it's a core responsibility of healthcare to embrace suicide prevention as something that all systems should be striving for. And it's seen that suicide is not inevitable, whether it's in emergency departments, whether it's taking care of behavioral health patients, substance use. There's a lot of comorbidity. Looking at women who are high risk during pregnancy or postpartum, we have to see suicide deaths as not inevitable. And as I said, it really is thinking about the whole system approach. This is a system of care that you're transforming, not individual behavior of any one clinician. Next slide. All of these elements are important equally, and sustained attention to each of these elements, and I'll walk through them now. Next slide. So leadership, it's about culture change. You have to have leaders who are committed that suicide reduction is possible, suicide prevention is possible, and sets the tone that the system is going to adopt suicide prevention and care as a priority without trying to identify people when adverse events do occur, but instead learning from those adverse events. And it also includes the voice of lived experience, and not sort of bolted on at the end to say, do these policies reflect well on people with lived experience, but rather that people with lived experience from the get-go are sitting at the table and really thinking about how does it feel when somebody walks in our door, from the security guard to the person who schedules appointments, to the physician, to the nurses staff, to the follow-up care. How does that feel for the patient and their family? How are we doing to engage patients to ensure that they'll come back to the next appointment? Next slide. The workforce has to be competent, and they have to be confident, and they have to be caring, but it means that they need to have the skills to do this work. And we can't assume because people are licensed that they understand suicide care or that they've been able to keep up with the literature, because things have changed. A lot of the interventions that we now know are evidence-based have come through in the last kind of 10 years. There's a lot of research to support some of these best practices. So it's really incumbent on the system to train everybody in that system to their role and responsibility, what you're expecting of them. We do some surveys, healthcare systems, as they're adopting this approach. We disseminate something called the workforce survey. What our results show is that with a 1 through 5 scale, with 5 being I strongly agree and 1 being I strongly disagree. And what our surveys show, and we're talking about over 30,000 respondents, is that when you ask people, are they competent or confident to assess people or to care for people at risk, you get around 30% or so who say 5. You get another kind of 30, 40% who say a 4 out of 5, and then kind of it goes down from there. But kind of using the example that I said about, my daughter's surgeon, I want him to be a 5 out of 5. I want him to be a 10 out of 5 if he's going to do that type of surgery, that's really that invasive. We're talking life or death. And that's what we're talking about here too. We want people who we're sending our loved ones to feel comfortable and competent to provide care, not 30% of them saying, I strongly agree. So there's a lot of room for improvement, and that's really what Zero Suicide is it ensures that the system is making sure that their staff are well-trained and competent to do the kind of care that is necessary. Next slide. For screening, we need to know who's at risk. We have to screen everybody, and we have to screen them multiple times. People's life circumstances change. So just because somebody wasn't at risk when they first came into care doesn't mean that they're not, the next week or the next month. You have to screen at every visit. And for those people who screen positive, often people use PHQ-9, the Columbia Suicide Severity Rating Scale. But for those people who screen positive, they need to have a risk assessment to determine their level of risk. And that risk assessment needs to be immediate. You can't have somebody take a screener and then not check it for a day or two after they've just told you that they're at risk. The system needs to know who they're going to make a referral to, but not everybody needs to be hospitalized. We often over-rely on hospitalization out of fear, and that's not good for the individual at risk. Imagine spending 7, 10, 27 hours in the emergency department only to get sent home. And then you're just sent home right back to your outpatient provider who still doesn't have the comfort or the confidence. They're fearful, and that's why they sent you there in the first place. So if you think about this holistically, it's really important to have this entire package of activities well thought through, well planned, and comfortable to provide. The next slide. This is about engaging people, and it really begins with, first of all, making sure people that understand what suicide care is, what their symptoms are like, what type of care you can provide, how you can instill hope. Hope is so critical for people at risk for suicide, and it's really, we have to start there to tell people who are at risk, I can help you, I know what to do. We also have to use tools that are available, and that would include safety plans. And so all physicians, primary care, OBGYN, emergency departments can do a collaborative, meaningful individual safety plan. It's one of the best tools that we have at our disposal because it helps somebody to be both kind of more efficacious in managing their own symptoms, reduces their need to go to the hospital as long as it's something that they can really walk through. And these safety plans need to be updated at every visit and need to include reducing access to lethal means, because we also know that during the time that somebody's at risk, we need to ensure that they reduce their access to the means that they might use to take their life. Next slide. There are treatment approaches. Once you have somebody in treatment, you need to use evidence-based practices, not treat anxiety or substance use or some other issues and hope that the thoughts of suicide go away, but rather you need to use evidence-based treatment. Dialectical behavior therapy, collaborative assessment and management of suicide, cognitive therapy, brief treatments, ASIP. You need to use treatments that are going to target somebody's symptoms if we want those symptoms to disappear or go down. Next slide. And if we're going to make a referral for somebody, we should help them understand what is that referral for. As I said, we talked about providing hope. We need to tell somebody this person can help you. This is what they're going to do. Let's give them a call together. Let's talk about how you're going to get to the office. And what are you going to do in between times? Sometimes it can take weeks before somebody's actually connected from the emergency department to an outpatient provider or from primary care to a provider. You can use supportive and caring contact, text messages, postcards, phone calls. I get phone calls telling me that my dog has to go to the vet, right? And I'm more likely to go because I get those phone calls. My dog had surgery a couple months ago. I got umpteen calls to see how she was feeling. We need to do this for our patients who are at risk for suicide. We need to check in, see how people are doing. That keeps people in care, makes them feel very cared for, and it makes it more likely that they'll come back to the next appointment. Next slide. Everything we're talking about, you need to evaluate. Are you doing what you say you're doing? Are you doing it with fidelity? How is it working, and what can you change? And so the entire zero suicide model is really wrapped around the policies to support everything I was just describing, and the idea of using continuous quality improvement to modify what you're doing, to look at your data, report your data back to your team. Ideally, all of these practices are embedded in your electronic medical record. It's a lot easier to track on how different individuals are doing or different departments are doing. But this is not sort of a one and done. This is our 2021 initiative. This is years and of really thinking through suicide care. Next slide. We have a toolkit. It's free, publicly available, zerosuicide.com. So you can learn more. There's a lot of videos and a lot of other kind of information all about the different settings, different populations, mil vet, inpatient psychiatry, children and youth, and there's a toolkit about each of the different elements that I was just describing. Next slide. And next slide. Just a couple of resources to take note if you look through the toolkit. The first thing would be to take the organizational self-study. Again, just an opportunity for you to get a snapshot about how's your system already doing around many of the different elements I was just describing. It's a really good opportunity to hold a mirror up and say, are we doing as much as we can? Are we all on the same page even about how we think that we're doing? Next slide. I mentioned the workforce survey. This is also something free you can access via zerosuicide.com. And again, it's a great opportunity to say, you want to both get a snapshot of what are the elements of care you believe you're providing, kind of on a scale of 1 through 5, and how does your workforce feel about providing this care? It can help you set some training goals and also get some buy-in. Next slide. Next slide. And we have a couple of websites. We have the zerosuicide.com website I was just mentioning. It's got our toolkit. We have a very robust email listserv. There's about 3,000 people on it. People ask wonderful questions and kind of get support, so you can access signing up for that via zerosuicide.com or find the organizational self-study. And then for agencies that are looking for a little more training and support, we launched the Zero Suicide Institute, and that way we are able to do a little more training and education. Ed is one of our faculty who does training alongside our staff, and so I encourage you to take a look at both. And gonna turn it over to Ed. Thank you so much for having me.
Thanks, Julie. Next slide, please. All right, well, that was a really nice overview of the zero suicide model. What I'm going to do is tell you a little bit about our experience with implementing zero suicide at UMass. This timeline kind of got a little wonky during the translation, but this timeline starts in 2016. So if you look to the left of the timeline, you'll see a space that's kind of highlighted in yellow. And this is when we actually started our journey through zero suicide. We call our implementation of zero suicide at UMass the system of safety, or SOS. And we embodied the improvement component of the zero suicide model using a continuous quality improvement strategy called LEAN. So if you work in healthcare, you probably know about CQI, and you may have heard of LEAN. That's the kind of version of CQI we used. And what we realized is that it was really important to build our lean teams, the teams that were working on the implementation, to have representation from the units in which we were working in, including the management and frontline staff. We had IT, the health informatics, our EHR folks involved, and we pulled those multidisciplinary teams together at the unit level to work on mapping our current state. So in other words, what we wanted to do is get a really good idea of what we were doing currently to identify and manage and transition individuals with suicide risk in our health settings. And we started in our emergency departments, and then we transitioned from there to our inpatient medical units as well. So we spent a lot of time working on our current state maps and then identifying where the gaps were. So we knew what our future state should be because it was pretty well laid out by best practices in suicide prevention, both as they were, I guess, translated by the Joint Commission. So that's one way of thinking about the Joint Commission standards, is that it promotes a best practice in identifying and preventing suicide, but then there were other best practices as well. So we had this kind of this blend of best practices that we knew we needed to implement because there was a big gap between where we were and where we needed to be. During that process, we identified ways that we might be able to use the electronic health record to help to actuate our future state. So we engaged the EHR builders, and they helped to build some tools. For example, one of the things that we recognized is that we needed to do a better job with screening. Our screening process and the screeners we were using weren't really up to snuff. They weren't the best screeners that we could use. So we built those screening tools in the electronic health record so that they could be systematized and standardized and used within the EHR. And we were working to implement our revised clinical care pathways, our improvements. We worked to implement them at the unit level. So we would build a pathway for this emergency department, and then a similar but slightly different pathway for the next emergency department. And we try to do this because the feedback we were receiving, and if you work in healthcare, you probably will recognize this, but every unit and every ED we went to were telling us that their processes were different. They do things differently, and they couldn't be all standardized to follow the same process. So we try to accommodate that by implementing our care pathways in a very tailored way at the individual unit level. And I can tell you that we spent hundreds, maybe thousands of person hours on this effort, and it felt a little bit like Sisyphus rolling the rock up the hill. And right when I felt like we were about to get to a breakthrough and really get some change, it would roll back down for some reason. And the progress wasn't non-existent, but it was definitely modest, and that persisted for a while until something really bad happened. And you see the big red splatter mark there right in the middle of the screen. And that something bad that happened was one of the hospitals in our health system, we have 5 hospitals, failed their Joint Commission visit, and failed it in a big way. Failed it to the degree that they had to overhaul their protocols that caused the failure overnight, literally overnight. And the reason why they failed their Joint Commission visit was because of their suicide prevention efforts. They were not following the Joint Commission's standards. And the reviewer basically said, if you don't overhaul what you're doing, we'll close the hospital. It was just, it's a bit dramatic, but that was the way everyone was interpreting it. And what I had been trying to help the hospitals do for about a year and a half with very little success, literally within 6 hours, was completely transformed. In fact, they adopted protocols that were way more intensive and way more labor intensive than what I had been trying to get them to do. In fact, way more than the Joint Commission probably really required. But as you know, if you work in healthcare, the response to a Joint Commission failure is panic and is overcompensation. I'm bringing this up though because when that hospital had this burning platform that they absolutely had to make change, all of the barriers that were in place before this, all of the resistance that we received from clinicians, from leadership, all of the kind of laxness around paying attention to this issue suddenly evaporated because there was a real and pressing need. And of course, the leadership that got involved at this point went all the way up to the president of that hospital. And they ended up completely overhauling their entire care pathway to better identify and care for patients with suicide risk. It was very unfortunate that had to be the cue for them to really take it seriously and to change their care pathways. But I'm bringing it up because I think it's a really important lesson in the difference between what was happening before and then what happened after. Because what happened with that one hospital failure is the rest of the entire health system realized that the same things that were happening at this small community hospital were happening at all the other hospitals too, including the big tertiary care hospital. And it brought this issue to the forefront of leadership because everyone recognized when they were looking at their Joint Commission dates and when the Joint Commission was going to come to evaluate their hospital, that they were all equally vulnerable. And especially once the Joint Commission finds a problem like this in a health system, when they come to review the other hospitals in your health system, you can bet they're going to be focused on this. This transformed the leadership engagement in our effort. Before, I thought we had leadership engagement because before this happened, I actually, had the president and CEO of the hospital sign a letter of support, and we had what I considered good leadership engagement. All the C-suite knew about what we were doing and were at least morally supportive of the effort. But it wasn't until the failure of the hospital that I saw what true leadership engagement looked like. True leadership engagement looks like when we have our big performance improvement meetings where we actually had 40 people from across the health system in a room for 8 hours, was the president coming to that meeting and actually being there, being present, the CMO, and having senior leadership sponsoring this effort, and having on the smaller steering committee the representation from a senior leader. So the vice president of patient safety basically took over the effort to be able to make the entire system compliant with our best practices. And it wasn't until that leadership engagement was real, where they were actually present, where they actually allowed the clinicians and the managers who were part of our teams to essentially get taken off of their shifts so that they could be present during the meetings. So that when we built our trainings, it wasn't just some sort of shadow training where we just had a bunch of PowerPoint slides that everyone would participate in and would get exposed to on our virtual learning system. Instead, the trainings that they built were real world trainings where we had at the elbow types of supervision. So when we went live, finally, after 9 months of preparation, we went live with new pathways across the entire health system. In fact, we revised some of the pathways that were at the hospital that had failed their Joint Commission visit, so that what we had then is a system-wide effort, all of which rose the standard of care to the best practice. And the only way that really happened was when there was real substantive leadership support. And that transition from pre to post really called that out to me. And it showed me that without the leadership actively being engaged and doing things like actually putting money behind this, and the way putting money or an investment into this looks like is what I mentioned earlier: people being present at meetings, modifying electronic health record to support the effort, actually supporting a project manager. So the other thing that we were able to get after the hospital failure was a project manager who took responsibility, actually 2 project managers who took responsibility for making sure that the effort was organized, was moving forward, and that when action items were generated based off of meetings, that they acted on it. In fact, they would build these small sub-teams, because sometimes when we're talking about how to standardize care across an entire health system, as you can imagine, there were a lot of conflicts. And so those project managers identified when there were complex issues that needed sub-teams to be managed, and then they carved out those sub-teams. Those sub-teams worked on these problems, came up with a consensus, and came back to the big team. Without that those really strong project management engagement, what was happening before is these conflicts would just drag on and would swirl forever. We never really got resolution, and there wasn't sufficient sort of accountability there. So the combination of that leadership engagement and the project management is what really turned this effort around. Now, I really had hoped, and what I hope will happen in your health system, is that you can learn from this experience and recognize that without those 2 key components, the leadership support and the project management, that it's extremely challenging to create a better system of care. And hopefully you can get that done before you have a Joint Commission failure, or God forbid, a suicide, a sentinel event, which would be even worse. So in closing, I just want to say that what we were able to push out in terms of our uniform policies and procedures was something that we never would have thought would have happened when we began the journey, because of the resistance that we had originally received from individual units and hospitals wanting to do things their own way. But when there was a real need for people to come together and to come up with a consensus and to work out all of the details, what we found is that there was an illusion of separateness, that what people thought was unique about their patient population or their unit, their hospital, really wasn't. And that when we came together, we could actually come up with common standards that we could apply across the whole health system. So right now, and we've been doing this for at least a year since our go live, all 5 emergency departments, actually 6 emergency departments, all of the inpatient medical units, all the behavioral health inpatient units are all doing using the same tools and following the same care pathways, and it's been working quite well. So I'm going to stop there and hand it back to Cindy and Joy.
Great. Thank you so much to each of you. we're going to share our cameras here and join each other for the fireside chat. Great. Well, thank you all. And Cindy, welcome back. We had a little technical issue there, and Cindy got us back on track right away. So Cindy will be joining us if you have questions. Anyone has questions about the peer perspective or the patient perspective surrounding suicide. Well, thank you again to Dr. Goldstein-Grummet. I'm going to use your full last name this time, Dr. Goldstein, thank you. And also Dr. Boudreau, thank you for your presentation. And really what we heard today was, what is the framework and how has it been implemented? And that's exactly what we were hoping to share with the audience today. There's 250 of you on live today, and I want to also acknowledge each of you. We know that you're champions in some way to deter suicide and maternal suicide in particular. So thanks for being with us. I should actually show this sheet. You can see all of my questions and the points that each of you have raised, and I've circled, like, don't forget to talk about this. So much to unpack here together. And I think we may want to do another session, just a Q&A with some of you who are ready to go deep in your health systems, Julie, or plug folks into the framework on an official basis in some way. But just thank you for all your interest, and there's some great questions that have come in so far. I think if we can start, Julie, with you, if we can ask you, why do you think suicide has been kind of a forgotten, and maybe even mental health for that matter, kind of this forgotten topic, health, a really incredible, important health issue that's sort of been left out of? Let's start with the emergency department framework. What was going on there? Why do we even need zero suicide?
Yeah, it's such a great question, and I'm not sure we know all the answers. There was an article, I don't know, maybe 8 years ago or so in Forbes called The Forgotten Patient. And so it was about suicidal individuals and how the healthcare system really doesn't pull them out and directly address suicide. And that we sort of rested with assumptions that to do work in behavioral health means you will lose patients to suicide. I know even when I was in graduate school, in some cases there was very sort of a negative feeling that if you work with people long enough, you'll probably have a suicide. And that became sort of accepted. And I think some of that was fear, right? It feels much easier to tolerate when that happens if you're afraid and you don't think the blame is on me, right? Then we end up blaming patients. And so I think that there's less money in behavioral health, and so training sometimes is lesser than happens in the medical world. When it's not driven by quality measures and it's not driven by sort of other kinds of indicators like the Joint Commission or CARF, then it really is at the discretion of the leadership to say, we're going to make this a priority. And in some cases that did happen, and those were some of the earlier examples of zero suicide or really enhanced suicide care. But those are kind of few and far between, and I think it's all of that combined. I think the suicide prevention field in particular in the last 5 or so years, especially the American Academy of Suicidology, AAS, American Association of Suicidology, established a separate chapter for people with lived experience, and really kind of this movement of we're still alive. You're doing all these sort of autopsy reviews of psychological autopsies of people after they've died and trying to learn about it from that, as though you can't speak to them. But in fact, you have a lot of people who have made suicide attempts who are still here. Ask us. We'll tell you what you want to know. And I think we've gotten a lot more sophisticated. We have a ways to go, but I think, that plus the advent of best practice, of some evidence-based practices at work have helped. Ed, you look like you were like, I have something to add.
Yeah, I think that the what you said is absolutely true. I think, unfortunately, in certain settings, especially the emergency department setting and probably medical inpatient units as well, it's not just suicide, it's all things behavioral health. that are marginalized. So the same conversation we have about the forgotten suicidal patient, we have about the forgotten opioid use disorder patient, the forgotten alcohol abuse disorder patient, depressed, panic disorder. It's just that the systems in certain areas are geared primarily for medical emergencies and don't really have capacity to treat or even to recognize behavioral health emergencies and behavioral health problems. And it's compounded by the fact that when you don't have a behavioral health specialist readily available, there's a huge system barrier to accessing a specialist, leaving care of these very vulnerable patients in a vulnerable time to medical professionals who, I guess that, to balance this out, they have to train in a whole lot of different things, especially if you're in a generalist setting like an emergency department setting. So they have just training and overload, things that they have to keep in mind. So I think, unfortunately, the behavioral health aspects get slighted, and it wouldn't be as bad if you had adequate representation of behavioral health specialists in those areas, but we don't. And so that's what makes the deficit among some generalists even worse. They would be happy. Every emergency physician in hospitals I know would be happy to have someone who's trained to deal with the suicidal patient be there and to be able to provide the best possible care. That's not usually the resistance. The resistance is finding those people. And that has to do a lot with macro system structures and reimbursement. It's just not profitable. So like Julie said, if you don't have that behind it, it's difficult to maintain a provider pool.
So incredibly helpful. 2020 Mom is looking at some of these things, and so I know I personally want to follow up with each of you on reimbursement issues. We all know about carve-outs and hospitals in this case, right? And whether hospitals who aren't considered behavioral health inpatient specialty hospitals might need separate contracts with insurance companies, for example, to get reimbursed. EDs, of course, are different, but that's one thing that comes to mind, and also obstetricians or primary care providers, right? And whether or not they can employ and bring on an LCSW. We're also looking at certified peer specialists, which we talked about. People with lived experience just have such great ability to impact outcomes here potentially. Julie, I want to ask you about that, each of you about that in just a moment. And so what does that look like in terms of contracts and payment reform? And Edwin, you hinted at like not enough reimbursement for behavioral health providers and perhaps EDs. So a lot to consider there. Thank you for that insight. And it lines up with what the field has been telling us about maternal mental health generally. We're getting some questions about, Julie, you hinted at sort of a safety assessment, and some of our attendees today are not in big health delivery systems or in emergency room departments, which really is great when we can start there to stop the bleeding. But for those who aren't in an emergency room department, an ED, and want to do something, can you tell us a little bit about sort of screening for suicide risk? What does that ideally look like? And then the sort of safety plan assessment. What do those tools look like?
Yeah, so those are some of the best tools, very well researched, and a lot of evidence to suggest they really are reducing suicides. So using the PHQ-9, the Patient Health Questionnaire 9, is a great resource. It's frequently used already in primary care. It's really questions 1 through 8 are more about depression. Question 9 is the suicide item. If somebody screens positive to suicide item, you need to do an immediate assessment. What's their level of risk? What needs to happen? So really good sources in your area. What are you going? Do you need to make a referral? Do you have behavioral health on staff? What you're going to tell the family, regardless of whether you're somebody to the emergency room or to Dr. Smith around the corner, you want to keep the individual safe and give them a set of skills to begin to help safety in the interim. And it may be safety for the next, hour. It may be safety for the next 6 weeks until they go to that provider, depending on their level of risk. So the safety plan, you can find the Barbara Stanley and Greg Brown developed one of the safety plans. That's you can access that on the Zero Suicide website. There's another one called Crisis Response Plan that Greg Brown developed. They're pretty similar. They're basically a prioritized set of coping skills. So what are your triggers? What are the things that might let you know when you're sort of at increased risk? What kinds of things can you do to de-escalate yourself? Really the idea being that we need to be able to learn the skills to manage our own thoughts of suicide, not, oh, you feel this way, you call 911, or you feel this way, you call your provider, or go to the nearest emergency room. It's really more of a stepwise progression of what can I do to distract myself? Who can I call in my system? One of the critical pieces of a safety plan might be if Ed is on my safety plan, I'm not calling Ed, so Ed can say to me, okay, let's call 911, or I'll drive you there. I've already, as the physician, talked to Ed and said, you're on Julie's safety plan, and when Julie calls you, these are the types of things you might do. You might talk with Julie about, you know, she loves to go for walks. She really likes to kind of drink coffee. She likes to watch stupid Lifetime movies, you know, and so maybe those are things that you can remind her that those are things that help to work to de-escalate her. You might, you know, chat with her on the phone, right? So Ed's not my therapist, so to speak, because he's on my safety plan. Ed understands his role. And if all of those things of me sort of managing my own increased stress, or my peers, my family managing my increased distress isn't working, then we can call my provider and my provider recommendations. It also includes really immediately what are we going to do about reducing my access to lethal means that both me and my family are agreeing to, that they're locking something up, taking it out of the house, but that there's confirmation, not, well, Julie, you have access to those pills, so just really give them to somebody when you get home, but rather my provider, so in this case, primary care, OBGYN, emergency room, is calling my family and saying, this is what we're agreeing to. This is how we can keep Julie out of the hospital. This is how we can keep her safe. And everybody understands their role in keeping me safe. So that's really what a safety plan is. And then ensuring my referral and making sure that I go, and not here's a list of 5 providers you should really call one of them, but checking, did I go? Calling me the next day. Do you need help with the referral? Do you need, you know, what kind of provider are you most likely to go see? What might obstacles be to you going there, right? If you're only going to give me daytime hours and I work full time, don't give me providers that don't have Saturday hours. So, you know, in many of these cases, it's really what would you do if you were diagnosing me with cancer, or you were sending me to, you know, an oncologist? You would describe what the oncologist appointment will look like. You'd probably give me some information about, you know, what to expect from some of those appointments. We need to do the same thing in behavioral health. We really need to acclimate the family to this is what behavioral health care is, and not just hand me a piece of paper. Good luck.
That was so helpful, Julie. And I'm guessing, Ed, you have something you want to add before you jump in. I would love for you each to talk a little bit or acknowledge from your perspective if any work has been done yet. And it may be the case that we need to unpack some of this together to address a mother's concern about going to an ER and having her baby taken away, being reported to Child Protective Services. You know, this is a real concern for a lot of mothers and families. If you could address that, and then anything each of you want to address, Ed, starting with you, around racial disparities and helping the BIPOC community, in particular the Black community, feel comfortable in this framework. Is there more work to be done there? We know everyone's really taking a harder look at what can be done around race. Anything you want to share on that front? Ed, we'll start with you and then come back to Julie.
Well, I wish that the fear of Child Protective Services being engaged during an ED visit was just the fantasy, but unfortunately it's not. I mean, that does happen. Although I have found that the threshold for engagement is pretty high. So I think most emergency departments are very reluctant to trigger a Child Protective Services evaluation, and for an individual expressing thoughts of harming themselves, most likely what will happen if they're in an emergency department is they're going to be evaluated or sent for an probably a consultant, a mental health clinician will come in to do an evaluation. And during that evaluation, they're going to look at a whole host of factors related to the mom's mental health and her support services and environmental services support whenever she gets home, to be able to make a decision as to whether or not she needs to be admitted to a psychiatric unit. So that's going to be the first decision to be made. I doubt seriously if it's not a case of concern that the person is doing something that might harm her child, that they're going to call Child Protective Services in. That's hard to assure patients of, because there are horror stories out there of things happening like that. So there's lots of anecdote, but generally speaking, I think reassuring the mom that the most important thing that the emergency department is going to be thinking about doing is trying to figure out where the best location of care is going to be for the mom, what level of care, if it's inpatient, IOP, or outpatient, and they're going to make decisions based off of that. And they very rarely engage Child Protective Services unless they feel like there's a real imminent risk for the baby. In terms of the disparities issue, this is a really important topic that has recently received a lot of attention because of some epidemiological research that's just been published in the past couple of years that have shown a really dramatic increase in suicidal behavior in African Americans, particularly younger transition age and young adult African Americans, which really wasn't the case before. So we have definitely seen a pronounced and non-chance trend here that says there's something going on. We don't really understand it yet. So there have been calls for trying to better understand this. You can speculate, probably rightly so, that it has to do with some of the problems the African American community is facing right now with the marginalization, with police violence, et cetera. There's a lot going on right now. So it could have to do with these societal trends, but nothing that I've seen to date really has nailed that down. But it's definitely something that we have to pay more attention to because of these the trends that we've noticed.
Julie, anything you want to add? No. Okay. Great. Just in closing, because there are some movers and shakers and change agents on the line today watching that might have influence over their health system. Can you tell us a little bit, Julie, your image about Swiss cheese, and that some hospitals are doing, like if we're at UMass, amazing work, Ed, thank you. That's great. And then what about if we're in a rural community health, a community-based hospital, community hospital that hasn't quite got here? Are there strategies for hospitals to obtain grants, like this sort of carrot and stick notion? Is the Joint Commission accreditation enough? Are there some hospitals that still aren't going through Joint Commission because maybe there's no competition? What are the carrots and maybe what are the sticks? Do we need some additional policies here?
Yeah, it's a great question. I will say there's a lot of systems doing zero suicide that are not Joint Commission accredited, and they're doing it because they're seeing suicides in their system that they thought were preventable, or it frankly just makes sense. And they think, in a lot of systems, while you asked about grants, it may be that people need money certainly to redesign their electronic medical record to add all of this, or they may need money. Often systems hire a zero suicide coordinator, but not always. And so most systems are doing something to screen people for suicide risk. They can be more effective, but what they might be doing is leaving it to clinical judgment, right? It doesn't really cost anything to use the PHQ-9 as a free tool. It takes seconds to, administer. So it's really, it doesn't cost anything. You're already having conversations if you've identified somebody as at risk. Using standardized tools like the Columbia Suicide Safety screening tool and assessment is a better tool than using clinical judgment. You want clinical judgment to be a part of it, but using these standardized tools so that it's not different if you enter Ed's office versus my office versus Joy's office. Doing a safety plan doesn't cost anything. It costs time, but if you really kind of are able to take a step back and think, what is the cost involved in crisis intervention and hospitalizing people and what we're putting our patients through, what we're putting our families through, what we're putting our staff through, if you're able to really think differently about it, it's really a reallocation of resources in a lot of cases. A lot of systems have found, and it's who's saving the money. Some systems have found that they're reducing readmissions to hospitals. If you're the primary care provider, that may not be saving you money, and if they're not part of your system or your network, but you may be finding that patients are coming back and you're having fewer no-shows, so which makes you more productive. I think it's certainly rural settings can be very effective at utilizing this model as well. It's not specific to hospitals. We see examples of it in emergency departments, primary care, inpatient, outpatient, hospital systems. We've done work with Indian Health Service. We've done work with the Air Force. So I think there's absolute relevance across all different types of healthcare systems. My contact information is included in the slides. And so anybody is free to reach out to me and, continue this conversation or learn more about how to get started.
That's great. We have a few questions we didn't get to. Ed, anything you want to say before we close? We're just a minute over time here.
No, I think Julie said it well, and I think any questions that I can help with, I can be reached through LinkedIn or by email.
Great, good. And we will be following up with everyone who has registered with a copy of this recording and also some additional Q&A for the questions that we didn't get to. They're quite good questions. Julie and Ed will be sharing those with you, and we'll make sure we can answer them in our response with the recording in the next 48 hours. So thank you so much for joining us, everyone. Thank you to our two speakers. Cindy, thank you for setting up the webinar. So wonderful to have you, and we know there'll be more ongoing conversations about maternal suicide with each of you. Thank you so much.
Thank you so much. Take care.
Thank you.